when I look back, I was involved in research back in the 70s, which just seems such a long time ago. And I was working at the University of Queensland Medical School, and part of my role was to support a research project that would take ear, nose and throat specialists up to Thursday Island. And then I had no idea that I would move into research, but right back then it taught me how important it was to be systematic and have things in place, because we were flying in audiometrists who would screen the children first for hearing problems. Then we would fly in a surgical team, and we had a portable operating theatre. And looking back now, I think I learned then the importance of really preparing for any project that you're doing. But my actual training, believe it or not, is in journalism. Advertising initially. I went straight from school into an advertising agency, ended up being a copywriter. Then I did a degree at Queensland University in journalism and moved into public relations, but worked always as a health consultant. And I guess that's what then started my interest generally in health. But it also, even looking back then, honed my interviewing skills, my writing skills, which have been so helpful today. And then I moved to Sydney, because I was born in Brisbane. I moved to Sydney to take up a job with an overseas aid agency, and part of my role was to travel into Southeast Asia and the Pacific to visit aid projects and report back to the government on funding and what had happened with them, and do final reports on various projects. So again, there was this, inquiry, finding out what was happening, writing up the results. And really, I then moved, that's when I think I started seriously to move in towards bereavement initially, because I started off, I worked with Canteen as the first New South Wales coordinator, so that's the Australian Teenage Cancer Patient Society. And there I would run support groups, and at the same time I was training with Mel and Di McKissick in bereavement counselling. And I had a part-time job at Sacred Heart Hospice as a bereavement counsellor. So this was in the 80s. So right back then, a large percentage of the patients in Sacred Heart were HIV/AIDS patients. So I worked at Sacred Heart as a bereavement counsellor, and then worked at Prince of Wales Hospital at that time as the coordinator of Canteen. And eventually the Canteen position became full-time, and with my bereavement counselling training, because I spent about 5 years working with Mal and Di McKissick as a volunteer after I finished my training. So then I was the Executive Director of the Children's Leukaemia and Cancer Foundation, which was my first exposure to lab-based research, really, and went from there to work, interestingly, with the Cancer Council on their telephone support counselling line. And I guess it was then that I started to hear of the work of Leslie Fallowfield in the UK around doctor-patient communication. And I was aware of Martin Tattersall and Phyllis Buteau's work. And I guess if I had to give advice to researchers, that would be my very first one. Never be afraid to approach your heroes and say, I like what you do, can I work with you? So I literally sent a cold call email to Martin Tattersall and said, I'm really interested in doctor-patient communication. Could I come and talk to you about it? And I look back then, and I think this is so important in terms of mentoring, and I try to do it now with younger researchers. Martin said, well, I can only see you for a breakfast meeting. I said, fine, I'll be there. So I turned up at Sydney Uni, and he introduced me to Phyllis Buteau. And this was back in 1996, and to this day, Phyllis and I stay very, very strong friends. And that was really the start, because I met with Martin, met with Phyllis, and they said, well, have you thought about doing a master's? I went, because by this time I'd done my Bachelor of Arts in journalism, and then I also, when I came to Sydney, did a Bachelor of Adult Education in bereavement community education. And I thought, a master's. I never considered myself a student. I went, oh yeah, okay. And that introduced me to the whole process of grant writing and going for funds. And somehow Martin and Phyllis, through bits and pieces that were tacked on to other research grants, managed to put enough funding together for me to do my master's. So the initial project was looking at communication of prognosis in early stage breast cancer. And that's where I really cut my teeth. I did the first year of the pure research studies, your statistics, your research design, methodology, etc., and then a minor thesis. And I recruited women just after surgery with early stage breast cancer, looking at their understanding of adjuvant therapy, and particularly looking at some of the maths when doctors say, you know, you've had your surgery, there's a 30% chance this cancer could come back, but if we were to give you chemotherapy or radiotherapy, we would reduce that by 30%. And then our study said to the women, so what are your chances of cure from this? And I then got really interested in it, was how it was described, whether words were numbers or numbers were used, and around communication. And at that time, Stuart Dunn was also working with Phyllis. This was before Professor Stuart Dunn, before he moved to North Shore, to the Pam McLean Centre. And Stuart, of course, was very keen to get people involved in the communication skills training courses that he was running for medical students. And so I started facilitating courses for medical students in two areas. The first was on how to break bad news, and the second one was preparing patients for invasive procedures. And so that taught me a lot. We had actors who would role play, you know, real patients, and they would do it very well. But just working with these young medical students on how they might talk to people, what they might say, how they would deal with distress when that occurred. And I guess that's what then got me down this track of looking at doctor-patient communication. So I finished my master's, which was great. Working from having completed my master's, I then went on to do a PhD, which was looking at genetic counselling and familial breast and ovarian cancer. And that was when I began to appreciate that what is happening to the patient, to the woman in this situation, particularly in familial cancers, not just breast and ovarian, has this ripple out effect to the rest of the family. So you're not just dealing with the woman, you're dealing with her daughters, her aunts in this particular scenario. And so I was particularly interested to see how family members would cope, where a woman had had a genetic test for BRCA1 or 2 gene, that test was positive. How was that information then communicated to the other family members? What were the barriers? We found that a lot of younger women would come in at around about the same age that their mother or their aunt had been diagnosed or had died, and that there was really a lot of distress around this, and so that also had an impact on information and their ability to take in information. And so I think what I learned from that as a researcher, and the messages that come out of that, is when you're doing research, it's so important to be aware of where the subject of your research is, you know, where they've come from, what they've experienced. Of course, vitally important that you go through all the appropriate ethics approvals, and that in itself I think is it's a huge learning curve, but it's an amazing process, because if you fill out a 90-page NEEF, you sure know what your study is about and the ins and outs of it, and it really forces you to be very clear. Because I think when you're working with patients and families, there is a very strong ethical component, and this is about not being a burden. It's about you're asking people to participate in your study at a time when they're most vulnerable, and so you really need to hone your questionnaires, your interviews, whatever it is that you're doing, to adapt to how that person is. You know, ethically, if they've just been given the information of their cancer diagnosis, you need to be careful in your timing about that. One of the things I learned very early on was the importance in working in with the treating doctor. And because my studies at the moment in palliative care involve interviewing patients with not just a life-limiting illness, but their cancer has advanced, and so this will indeed shorten their life. But it's really important to know what the patient understands about their situation, instead of me going straight in and saying, now, you know, I understand that, you know, you have metastatic whatever, can you tell me more about that? And the patient may not even be aware of that or understand that language. So I think as a researcher, there's this ethical imperative to do no harm, to make sure that you've got all your ethical protocols in place, to make sure that you're working in with the patient or other family members or the treatment team, and is this the appropriate time to do the interview? Are they having a bad day? Being very conscious of that people are vulnerable, that they're fatigued, they may be nauseated, and that I think a key message is that your research goal is not what it's about. You don't go in there, no matter what, I'm going to get this survey done or I'm going to get this interview done. It's about working with where the person is at, because it's just not appropriate. You may lose people to your recruitment, and that's part of what we do, but it should never ever, be at the cost of, well, I've got to get this interview done no matter what. It's being really patient and family focused. As I said earlier, I trained as a bereavement counsellor and then worked for 5 years within the bereavement care centre, as it was at that time, with Mal and Di McKissick. And I always remember at the time Mal said to me, because I was by this time heading down academia, I guess, and research, and I remember Mal said to me, if you want to do research in bereavement, you must work with bereaved people, because they will teach you more than any other university course. And so really for 27 years now, I've maintained a clinical practice in bereavement. And it's just taught me so much. And I've seen so many changes. I was recently involved in an international working group on death, dying and bereavement, looking at what was initially complicated grief, and then it was prolonged grief disorder, and now the DSM-5's come out and it's persisting grief, whatever. It changes all the time. But I think for me, the lovely balance has been seeing bereaved clients, teaching about bereavement, and I do one lecture with Year 1 and Year 2 medical students and also nursing students about loss, grief and bereavement. And I think that's so important early on in their training, because by that stage they're taught they can cure everybody and everything, and it's just important to have that into perspective. And so for me to have done bereavement counselling, to have done bereavement education and now bereavement research has just pulled it all together. And doing bereavement research is very challenging because, again, ethically you have to look at a certain amount of time, before you can approach someone to talk about what's happening. There's always the imperative to provide some follow-up should your interview have caused distress, and always, making sure that they have a contact number, because people can talk about something and be focused on it, and then it's only after you leave that suddenly it brings it all up again. So again, it's making sure that your protocol addresses all of those issues, being very aware again about the length of your questionnaires, the sort of questions you're asking, and I go through my surveys, and if you've got a validated tool, it's difficult, you can't change it. But if it's a semi-structured interview, I'm really careful about, what do I want out of this question? Is this really essential? Is this going to cause distress, and it's not really going to give me any information that's going to inform this particular question. So again, when you're working with bereaved people in research, you need to be aware that it takes longer than you think. Everything takes longer than you think. I think that's one of the key messages in research. It always takes longer. But it's so important in those early days to have everything in place. And then it's just patience. You approach people, not to approach them at the time of the anniversary. That people may initially say yes to a study, and then for whatever reason, they're not able to complete, and that's just part of it. And it's also part of the work in palliative care, which is why I think research collaborations in this area are so important. And this is happening more and more with the studies that we do, where it's no longer a lone researcher working in isolation that's receiving funding, and the funding's getting less as well. So it's a matter of collaborating. We work in with the clinicians, we work in with the bereavement counsellors, the social workers, the OTs, the physios, but research collaboratives where we can pool our resources, we can pool our patient population. So, if we get 10 patients from this group and 10 from another, eventually you start to build your sample size. So it's being aware that working with vulnerable populations, again, it's working with what's presented to you. I think one of the significant things when CareSearch came onto the academic scene to some extent was that part of my role where I work at Calvary is to encourage allied health research. And my brief specifically was to work with the social workers, the OTs, the physios, the bereavement counsellors. I'm also involved in clinical trials as well, so I do work with the doctors. And when you're starting out as a baby researcher, you don't know where to go. You haven't yet honed your skills in critical appraisal. I mean, I did the critical appraisal workshop 2 days ago because I continually need to update and make sure my skills are there. So I think what CareSearch has done is that when I'm talking to a junior researcher, and it may start out in the hospital as a quality project, and I say to them, so what do you know about this area? You know, what have other people done? What evidence is there that what you want to do hasn't been done before? And so to be able to send them to CareSearch where I know that it's evidence-based, that it's been well researched, it's well organised, because I think it can be very daunting for a new researcher to know where to begin, and if they had a bad experience to begin with, you know, you don't want them to start out on a research career that way. So being able to refer them to CareSearch, it's almost like a one-stop shop where they've got it there, it's been collected for them, it's been done in a systematic way, it's been done where it's collecting the best possible evidence, you've got links that can take you, and it's just a really good starting point for researchers. And then of course for more experienced researchers, it's where you go all the time, where I go all the time, because it's so, and even the contents, the email will come around with the latest version and I'll go to it immediately. Okay, what's new? What are the systematic reviews? What's come out? Oh, I want to look at that one. And so it's very easy to scan it if you're busy and see what it is you particularly want to look at, or you might find something that I can then bounce on to someone else because I know that this is something they're interested in. So it is a very good resource. I'm currently involved in building their bereavement hub, and it's really given me a behind the scenes view of just how rigorous this process is, and that when these hubs are built, the thought that goes in, I mean, at one stage I was reviewing 250 abstracts, you know, to see whether this was suitable to, and whether it captured what it was we wanted to capture. Because I think the other thing is that when you've got clinical people wanting to do research, time is crucial, and they haven't got time to be rushing all over the place. It's hard enough to fit in research along with everything else they've got to do. So if you can send them to the one place where you know it's going to be there, it's rigorous, it's well researched, it's getting them started, I think, on the right foot.